Hello everyone and welcome to my YouTube channel and the fourth in my playlist on Canine Chiari and Syringomyelia. I'm Claire Rusbridge. I'm a veterinary neurologist who's particularly passionate about this subject, and today we're going to talk about MRI interpretation, and this is specifically of clinical cases. We're not going to go into the BVA scheme for health screening of breeding dogs because that's something a little bit different. This video is probably going to appeal more to veterinary neurologists and neurologists in training, but some breeders and some owners may also be interested in it. So we're going to focus on how to interpret the MRI scans of dogs presented to you with Canine Chiari and Syringomyelia being a differential. This is much more complicated than people initially think because Canine Chiari is such a complex disorder. This image here represents all the different changes that we can see, but not every dog has every feature, and the degree of each feature changes with each dog. It's likely that these things are additive, so some dogs may have less frontal lobe flattening and more reduction or a greater reduction in the chorda fossa volume, or many variations on the theme, and so it can be quite variable between each dog. I've put here as a reminder the sort of spectrum that we see. This is a normal dog brain and a miniature schnauzer, so it's sort of more miniature dog. The larger breed dogs like German Shepherds and Golden Retrievers would have a much more elongated brain, but we can see here that we have these prominent olfactory bulbs. We have the brains generally shaped like an oval. We can see prominent sulci, which is the CSF between the folding of the brain, or the gyri, where we can see that the ventricular system is visible but not dilated. We can see that between the brain stem and the spinal cord is more or less a straight line. It's just slightly curved, and that the cerebellum has this kind of rounded shape. This is a normal Cavalier King Charles spaniel, and it is about as normal as you can get. So you never see Cavaliers that look like this unless they have a very long nose and look like they've been crossed with a Springer. So this is a normal Cavalier. We can see that the cerebellum is rounded, but it's still tight against the foramen magnum. We can see that it's more or less similar sort of shape to the miniature schnauzer here, but there is some frontal lobe flattening, and the olfactory bulbs are reduced in size, but they're more or less rostrally pointing. And then we compare this to the dog with severe Canine Chiari malformation with a secondary Syringomyelia, which we can see here. And we can see that we can't see the gyra very well because the subarachnoid space has been considerably reduced. In contrast, we can see that the ventricles are much more dilated, including the fourth ventricle. There's considerable flattening. The olfactory bulbs are considerably reduced, not too ventrally orientated in this dog, but they can become very ventrally orientated, and we've got considerable kinking here. So, when you're first assessing one of these dogs, and bearing in mind they don't come with these little labels on it, or nor these little labels on, the first thing that you want to look at is, are there changes associated with Chiari pain? And we have the normal here and all of the different changes marked on it, and the abnormal here. Again, they don't come with those labels on. Now, the first thing that should be said is this requires imaging of the entire cranium. The BVA scheme for as a health check for breeding dogs doesn't require the whole cranium yet. You can just get away with taking the back of the skull, and this is for economic reasons, that doing the entire cranium plus the spinal cord is a more expensive procedure, and with the screening procedures they'll often just get one entire grab, so as much of the cervical spinal cord as they can get in, and as much of the brain, and especially in those low field units, low field MRI scanners, then they only have a small field of view, so you're only going to get about 14 centimetres of dog in that one view. Bit different for the high field scanners. So if we're assessing a clinical case for Chiari pain, we do need imaging of the entire cranium. It is challenging, and because we can have dogs that have MRI changes consistent with Chiari pain and not necessarily have Chiari pain. So you must take into account the clinical signs. I'll use the Chiari Checker, which is an app which I am developing currently, but hopefully if you're viewing this video in a month's time will be available. So you must take into account the clinical signs and not just the MRI. There is no objective assessment yet, so this means there's no score that you can give for these. It's still very subjective, but this is an ongoing research goal that we're doing at the University of Surrey, where I work as part of a sort of machine learning AI approach. For the actual specific MRI sequences, I'm not going to go through those in this video because, let's face it, they're very, very boring, but see the blurb that accompanies this video for those sequences. So let's take an actual case and go through its interpretation. So this is a 5-year-old female Cavalier King Charles Spaniel, and she's presented with uncharacteristic aggression. Aggression, of course, is in inverted commas there, because is the dog truly being aggressive or is she being protective for some other reason? And this was defined as growling and biting the owner when the owner went to go and stroke her and pet her. But quite importantly, this is when the dog concerned had taken herself off to her own bed, so she'd actually sort of withdrawn. And on a clinical examination, I mean, the vet didn't find any signs of aggression whatsoever. This was the sweetest natured cupcake of a dog that you'd ever hope to meet. This is why it was so uncharacteristic. On clinical examination, the vet found some spinal sensitivity, but otherwise she found it really quite unremarkable. So I'm going to take you step by step for my approach with assessing these dogs. First of all, look at the overall brain shape. Is it a soccer ball shape? Is it round? Or is it rugby ball shape? And those for the Americans or other nationalities that don't recognise this as a football and recognise this as a football, then this is the American football shape. So does it have American football shape, rugby shape, or a round soccer shape? And as the dog progresses towards a risk of Chiari pain, they become more brachycephalic. The height of the brain gets higher, and the length of the brain from nose to back of skull becomes shorter, so it becomes a more globular shape. So you should also look at the forebrain. Is this being flattened? And look at the olfactory bulbs. Are they reduced? Remember my normals in a couple of screens back. And are they becoming more ventrally orientated? And in this dog, I feel that it's definitely heading towards a rounder shape. You can compare it to this dog here. It has reduced olfactory bulbs, it has some flattening at the front, and so yes, I would say that this was a brachycephalic dog, and therefore at risk. That's the first thing, though. Doesn't mean that it does have it. The next thing I want to look at is the nasal tissue. Is there a frontal sinus? Or, as in this dog's case, are we going air, skin, bone, brain? So the so-called forehead is actually just the bones surrounding the brain, whereas of course in a human or in some other breeds of dogs, the front part of that brain would be protected by a frontal sinus. We just have a very small frontal sinus in this dog, none in this dog. And is there a pronounced stop, which is the junction between the nasal bone and the frontal bone? And we can see in this dog that there is indeed quite a defined stop, and we have some reduced nasal tissue there. So that will increase this dog's risk, bearing in mind that it's the reduction here which forces the brain back, and then also a shortness here which gives the overall condition. If that's something that seeming like a foreign concept to you at the moment, then perhaps review the first video in this series, which was on Chiari malformation. So the next thing that we want to look at is the cranial cervical junction. So this is the junction between the cranium, the brain, and the cervical spinal cord and canal here. So First of all, is the very classic, is there actually a cerebellar herniation? Now, some people get very confused about this, and they're expecting to see cerebellar tissue in the spinal canal, because this is what it would be if it was human. But in the dog, it can be so tight in this area that actually, the cerebellum has no opportunity to come out into the cervical spinal cord. And actually, in many cases, there isn't a dramatic cerebellar herniation. The other area of confusion is that sometimes people think this down here is the end of the skull. It's not. This little tiny bit here is a membrane going between the end of the skull and the first cervical vertebrae, which in these dogs is much more vertical than you would expect normally. Normally it would be horizontal. So where I've got the pink arrow there, that is the bottom of the skull, or the top of the foramen magnum, and that is where we're supposed to have seen the cerebellum stop. So in normal circumstances, the cerebellum would curve like this if there was enough space, but in this dog we can see a triangle of tissue coming out. Therefore, yes, this dog does have a cerebellar herniation. Is there kinking of the medulla, which is here, and the cranial spinal cord, sort of indicated by these blue arrows here? And we can see, well, actually, a little bit, not too much in this case. And that's quite important, because that kinking and overcrowding in that area is associated with risk of syringomyelia. And so we'd actually expect, if it was very kinked, to see a big syrinx in this dog. Can we see CSF that's in the foramen magnum? So the CSF is obviously white, and we can see it here in the cisterna magna. The cisterna magna is quite small. We can't really see anything round here. If we compare it to this dog, if you can get in close, we can see a little bit of CSF in this region, and perhaps a little bit more in this dog here. And then we want to assess the occipital crest, because it's often reduced in these dogs, and it is certainly in this dog reduced compared to that dog and that dog. And does the supraoccipital bone look normal? Does it have a curve coming out, or is it quite flat or reduced in this case? And it certainly is reduced and quite flat in this dog's case. So yes, we have a degree of a craniocervical overcrowding. It's not severe, so I would class it as moderate in this dog. So the next step is to look at the CSF spaces. So first of all, we're going to look at the sulci. Are they well defined, especially rostrally? There we have a normal dog, miniature schnauzer. There we have a normal Cavalier. No, we cannot see these sulci, especially rostrally. These do seem to be reduced in prominence. Are the ventricles dilated? Okay, this is the normal dog. This is the normal Cavalier. Yes, that lateral ventricle does appear to be dilated, and when we take the transverse view, we say yes, we've definitely got some dilation here. We also have dilation a little bit of the third. We can see that a little bit more prominently here. And we definitely have dilatation of the fourth ventricle. This is another area of confusion. The fourth ventricle should look like a slit. If it looks like a triangle, then it is dilated. And that's quite important, because whenever we see dilation of the ventricular system, we have to think, where is the obstruction? There has to be an obstruction to the CSF flow. And if the fourth ventricle is dilated, then that would suggest that there is a disruption to the outflow of the CSF through the lateral apertures, which are the side. So we have some moderate ventricular dilatation, a reduced subarachnoid space, and that ventricular dilatation includes the fourth, which suggests an obstruction of the lateral aperture. So the obstruction is occurring in this area here, and it's not severe. This is moderate. So taking all of those components into consideration, I would conclude that this dog is at risk of having Chiari pain. But now we need to assess the spinal cord for syringomyelia, and we need to rule out other causes of spinal pain, because, and obviously in this dog presenting with aggression, we have to look at the whole picture. But uncharacteristic aggression in this dog in a predisposed breed, it's very important to consider that the dog might be in pain. And it's a very sad fact that about a third of Cavaliers coming into rescue, the reason cited for them being rescued is actually aggression, which is particularly sad because these dogs are normally renowned for their gentle personality. And we have to think why it is that they are being presented with that clinical sign. So, our imaging goals for interpretation of syringomyelia. First of all, is there syringomyelia? And the next question is, where is it? And for this, we really need to have sagittal imaging of the entire spine. And some of you are thinking, no way, Jose, am I imaging the entire spine. That would mean moving the dog and would be much more expensive. For those people, I would suggest a haste image, because you can get a rough picture relatively quickly. It takes a sort of myelogram type appearance, and then it can tell you whether you need to do further imaging. And again, I put the protocol in the blurb for that. And we also need to ascertain what is the cause of the syringomyelia, and that's something that I haven't covered in this playlist. We covered the pathogenesis of syringomyelia where it relates to Chiari malformation, but syringomyelia will occur wherever there is CSF obstruction. So it's not good enough to diagnose syringomyelia. That's a bit like diagnosing anemia. It is a sign on a diagnostic image. You then have to decide why there is a syringomyelia and where there is a CSF obstruction. So this is a case of a post-traumatic syringomyelia. We can see the syrinx here and the pre-syrinx here. And this is a kitten that had an RTA, well, we presume. Actually, it's not known. It was a rescue from Cyprus. This L2 vertebrae is very short for the L2 vertebrae. Looks a bit odd. So suspect that it's an old fracture. This also here looked like a subluxation between L2 and L3. When we do some other images, we get the impression of adhesions in the subarachnoid space. Now, to appreciate those adhesions, you may need to perform a steady state image, for example, a CIS or a Fiesta, to be able to appreciate them. So what does our dog look like? Here it is. So I have imaged pretty much the whole spine. I haven't actually gone down to the lumbosacral image, or at least shown it for you, because mostly when there is a syringomyelia, it will occur in this region, not in this region. We'll also here, so the sites which we talked about in our pathogenesis of syringomyelia video, the sites in a Cavalier King Charles spaniel is to develop here, and then develop in this region here where there is spinal curvature. In some other breeds, such as the French Bulldog, you may have a much bigger syrinx here in those very brachycephalic dogs. So we can see in this dog there's a very small syrinx here and not much to see everywhere else. There is, however, some bumpy bits here, and we may want to further, or we will want to further check those out with transverse images to see if there is a significant disc herniation at that point, and another explanation for that spinal pain. I've put some figures in here because there's another sort of source of confusion. What is the normal central canal? Well, actually that hasn't been defined, but generally neurologists and radiologists take the normal central canal diameter as being less than 1 millimeter. So from 0, not being able to see it at all, to 0.9 millimeters. A dilated central canal being 1 to 1.9 millimeters. And syringomyelia, the consensus is to be a dilation of more than 2 millimeters. And in this dog, it was just about 2 millimeters. And so a very small syrinx in this dog, which would fit in with her MRI signs as well. We do need to look, as I've inferred before, for other potential causes of pain. I've altered the windowing in these sagittal images just a little bit so that you can see what I'm trying to point out. So this was a 7-year-old Cavapoo. She had actually been managed for a number of years with for Chiari pain with mild syringomyelia. She was represented because of acute onset and severe pain. And the imaging actually revealed that there was a very small disc extrusion. It's actually quite difficult to see unless you're really concentrating and looking for it specifically. So it'd be very easy to overlook this because your eye is drawn to the syrinx. These are both the same dog, it's just two different slices because this is a very eccentric disc protrusion. So we can see that there is the intervertebral disc is not quite as bright signal as in other places, and we can see just a little blip above here. Looks fairly normal here, so you do need to look at multiple sections in this dog, and it goes without saying this is much easier in a high field unit compared to a low field unit. We can see how mild syringomyelia, we do a transverse through this region, we can see just a little bit of a protrusion, extruded material here from the disc and the syrinx there. If you don't believe me, this dog was actually part of a study that included CT, and we can just see the calcified disc material just there popping out, and just there. This image here corresponds to there. So we need to rule out other potential causes of pain, especially if the pain is acute onset and severe, because most dogs with Chiari pain will have a history of pain before that. Of course, this dog did, but this was a very different nature of pain. So we need to establish whether or not the syringomyelia is clinically relevant. I normally take transverse images through all the wide parts of the syrinx, so demonstrating where I would take the transverse images here. And a clinically relevant syringomyelia in a Cavalier King Charles Spaniel be 4 millimeters or more. I would reduce that obviously for our tiny breeds to 3 millimeters or more, but that hasn't actually been defined. And you have to bear in mind that a syringomyelia results in a myelopathy, and the neurolocalization corresponds to the wide syrinx. So we talked about this before in clinical signs. You can't find a wide syrinx here and it be the cause of epilepsy in the brain. That is not the correct neurolocalization. Epilepsy is a forebrain disorder. So the clinical signs need to fit, just like any other neurological case that you're working up. Well, also looking not just at the width, but also if there is extension to the cervical superficial dorsal horn at the 10 or the 2 o'clock position, and the sort of mid-cervical region here. Also in the other areas of spinal cord, but it's particularly important here because we associate that with phantom scratching, which is ipsilateral to that cervical dorsal horn involvement, and also to scoliosis, where the shoulder is out ipsilateral to the involvement and the head is down contralateral. So those, as we talked about in clinical signs, the syringes that are associated with spinal with phantom scratching extend right to the nerve root entry zone and are typically in the C3 to C5 spinal segments. And so if you have in your clinical history of phantom scratching, then you really should assess whether or not the syrinx would be expected to be associated with that phantom scratching. And if it's to the shoulder region, then it should be here. If it's to the sternal region, then you can get some sort of dorsal horn involvement down in that cervical thoracic region. So if you are reporting these, you should make some kind of assessment as to whether or not these are clinically relevant. Large syringes will expand the spinal cord, whereas small syringes, as we saw in our previous case, going back here, will not expand the spinal cord. We will see a subarachnoid space around the spinal cord. And that's another way to assess whether they're clinically relevant. So in all of these here, the spinal cord is expanded, so therefore much more likely to be clinically relevant, as well as being wide. Well, the two go together, really. So in this one, where the spinal cord is not considerably expanded, even though there's a large hole, it may not be clinically relevant, or it probably is clinically relevant, which we talked about. You know, a donut is still a cake in the third lecture in these series. So, if there is extensive dorsal column involvement, then you may get mild proprioceptive deficits and weakness, but it can be really surprising how wide a spinal cord, wide a syrinx can get, and the dog can still walk. And that's because dogs actually, for their pelvic limbs, require very few axons to continue to walk. So paralysis is not a feature of degenerative myelopathy, thanks to Cavalier Health for this image. This is a dog with degenerative myelopathy. If there is severe grey matter involvement in the C5 to T2 area, so in this sort of region here, that will damage the grey matter, and we can get thoracic limb weakness. This dog shows some stumbling here, and spinal weakness in this region, trauma to those digits, as we've discussed before. This was quite an interesting little MRI scan here, because one thing that can happen to some syrinxes is they can eventually burst through that nerve retention zone, and this was one such example with a little bit of fluid on the outside. When they burst, the clinical signs can often dramatically improve, and that's also been shown in humans. So our next test is, are there signs that suggest progressive syringomyelia? So in this dog, she's 8 months old, we can see that there is much effacement of the gyra. We can't see that CSF signal at all. She's got a quite dramatic cerebellar herniation here. And very importantly, we can see a fluid void because of fast moving CSF in that spinal syrinx. And we can also see here a pre-syrinx. So this is an area where it hasn't actually formed a syrinx yet. It's just edema in the spinal cord. And when you see this fast moving fluid here, then that is a warning sign that this syrinx is likely to progress. And so that should be in your report as well. We can also see that there's high velocity fluid just in this region before we get into the syrinx, and you can often see a high velocity fluid in the brain as well, for example going through the mesencephalic aqueduct. 3 years later, the dog's clinical signs have actually settled down quite considerably, and that's probably because the end state has been achieved, and actually the whole system is at lower pressure. And we can see that we have the gyra have reappeared, and that the high velocity fluid is much reduced. We can see one fluid void here. However, she did progress to have a really, really extensive syrinx. This is one of the most extensive syrinxes that I've seen. And she did have some weakness associated with that, but actually less pain than when she was 8 months old. The owner was actually quite surprised to have this image. Something we're going to talk about in a later lecture, but I just want to say, whilst we're talking about imaging, that syrinxes do not grow over time like this. There is not a progressive expansion over time. They tend to progress really quickly over a number of months or years, and by the age of 3 most syrinxes have stabilized and will grow only minimally over that time. So bear that in mind when you're trying to explain prognosis to owners. So I'm going to conclude there. If you'd like to have more information, then a very much easier to read paper is here and vet in practice, and that's not normally an open access journal, but made open access thanks to Cavalier Health. .org and the charity associated with that. And if you need even more information, then read this paper here. This is essentially what I've been talking about, but in words form. And there it has a partner paper there, which is the embryology of Chiari malformation and syringomyelia. So that concludes our journey through MRI interpretation, a little bit of a whirlwind. And so if you need more information, then explore the links in the blurb. First of all, the protocol is there, and also the links to the papers that give this in much more detail. Thank you very much for listening to me. Our next topics will be on treatment and a little bit on the prevention, both and the health screens. Bye-bye.